Welcome to this explainer. Today, we're taking a pretty dense list of pharmacological guidelines and transforming them into a tension-driven masterclass. We're going to talk about managing one of the absolute highest stakes, time-critical clinical scenarios you can face, the hypertensive emergency. If you've ever stood at the bedside, watching a monitor flash those critical blood pressure numbers, you know the pressure's on, both literally and figuratively.
Here is our roadmap for today. 1. Defining hypertensive emergency. 2. The balancing act, focusing on BP goals. 3. The IV drug toolkit. 4. Matching the drug to the disease. And finally, 5. Stepwise management and rules.
All right, let's jump right into Section 1, defining hypertensive emergency. What exactly are we facing here?
So the crucial point to remember is that a hypertensive emergency isn't just about the scary high numbers on the monitor. It's the critical combination of those severe elevations, usually we're talking over 180 systolic or 120 diastolic, combined with active, acute target organ damage. That's the combo that demands immediate intensive care and intravenous intervention. Honestly, it's the organ damage that flips a severe hypertension case into a true red alert emergency.
And when we say target organ damage, we literally mean your patient's most vital systems are actively under siege. We're looking for neurological deficits in the brain, acute ischemic changes in the heart, tearing in the aorta, crash in kidney function, or even visible hemorrhage in the eyes. Identifying exactly which organ is failing is step 1, which brings us perfectly to our next major concept.
Section 2. The balancing act, BP goals. This is all about controlled reduction over rapid normalization.
Let's just address the elephant in the room right away. When you see a blood pressure of, say, 220 over 130, it is the most natural instinct in the world to want to slam on the pharmacological brakes and drop that pressure instantly to 120 over 80. But doing that, it's incredibly dangerous. You see, the body has already auto-regulated to that high pressure. If you drop it immediately, you could critically deprive those already stressed organs of blood flow, causing catastrophic ischemia. We definitely don't want that.
Instead, you've got to think of this timeline like precision braking. You want to pump the brakes systematically. In that vital first hour, your goal is actually just to reduce the mean arterial pressure by 10 to 20%. That's it. Then, over the next 2 to 6 hours, you're aiming for roughly 160 over 100 to 110. It really takes a full 24 to 48 hours before you actually want to completely normalize the blood pressure. You absolutely have to respect these specific intervals, because if you slam the brakes too hard, you crash the patient's entire system.
Moving on to Section 3, the IV drug toolkit. It's time to meet your roster of specialists.
Before we introduce the actual team of drugs, let's look at the resume we are hiring for. When choosing our intravenous weapon of choice, we need something that hits fast, wears off quickly if we happen to make a mistake, is easily titratable, has a predictable effect, and most importantly, preserves blood flow to those vital organs we were just talking about. All right, let's look at the stark contrast between our two major calcium channel blockers. On one side, we have nicardipine. This is our steady, reliable all-arounder. It has a great, predictable onset and fantastic cerebral protection, which basically makes it the default for most emergencies. Now, on the flip side is clofidipine. This is an ultra-fast sprinter. It works in mere minutes and is an incredible ICU drug. But there is a catch. It's formulated in a lipid emulsion, so it is uniquely contraindicated if your patient happens to have an egg or soy allergy or a defective lipid metabolism.
Next up, let's compare our beta blockers, labetalol and esmolol. Labetalol is your versatile multi-receptor blocker. Because it reduces peripheral resistance while protecting cardiac output, it's absolutely brilliant for eclampsia in pregnancy or an acute ischemic stroke. But then you have esmolol. Esmolol is an incredibly short-acting sniper. With a 1-minute onset and just a 9-minute half-life, it's the absolute go-to for aortic dissection, where you need immediate, extreme control of the shear stress on the aortic wall.
Now for the direct vasodilators. Sodium nitroprusside is incredibly potent, acting in literally seconds to dilate both arteries and veins. However, it does carry a pretty scary risk of cyanide and thiocyanate toxicity. Plus, it can actually increase intracranial pressure. Nitroglycerin, on the other hand, is specifically tailored to act as a venous reliever. It's really not your general antihypertensive. Instead, it shines by decreasing preload and myocardial oxygen demand, effectively saving the day during acute pulmonary edema or acute coronary syndromes.
Finally, let's talk about a couple of very special alternatives. Hydrolazine is primarily kept on standby for eclampsia and pregnancy emergencies. It's effective, sure, but it can cause this unpredictable reflex tachycardia and prolonged hypotension, so we don't really reach for it first in other scenarios. And then there's phenyldopam, which is our ultimate kidney protector. It's a highly unique, selective dopamine D1 agonist that specifically opens up renal blood flow and promotes sodium excretion. That makes it a brilliant choice for patients presenting with acute kidney injury.
Okay, Section 4, matching drug to disease. How do we choose the right weapon for the job?
Consider this your ultimate clinical cheat sheet. Notice how nicardipine shows up almost everywhere as the reliable default? But look closely at the nuances. If a patient rolls in with acute pulmonary edema, you really need nitroglycerin to handle that preload. If they have preeclampsia, you're reaching for labetalol or hydrolysine. And pay super close attention to aortic dissection. This specific crisis absolutely requires the heart rate lowering precision of esmolol first, followed by a vasodilator like nitroprusside.
And that brings us to Section 5, stepwise management and rules. Let's lock in those protocols for safety.
Crucially, we absolutely have to talk about what not to do. It can be super tempting to just give an oral med while you're scrambling to set up the IV line, but you must never, ever use immediate release or sublingual nifedipine in a true emergency. Dropping the pressure rapidly with an untitratable oral medication is a one-way ticket to precipitous hypotension and catastrophic ischemic events in the brain or heart. Seriously, stick to the IV.
Since you're walking this crazy tightrope between severe hypertension and treatment-induced ischemia, continuous monitoring is totally non-negotiable. If you have an arterial line, use it. You need constant ECGs, frequent neurological checks, and precise tracking of urine output to make absolutely sure those vital organs are actually surviving and recovering while you treat them.
So here's everything we've talked about, synthesized into a flawless 6-step algorithm. It goes from confirming the actual threat and getting the patient into the ICU to starting the monitors, matching the specialist drug, and then precision breaking the blood pressure over a matter of hours. You just don't rush it, you follow the curve. And finally, you only land the plane safely on oral therapy once the patient is fully clinically stable.
As we wrap up this explainer, I want to leave you with this question to chew on. The next time you face a flashing red monitor in the ICU, how will you master the balancing act? Remember, the goal isn't just to make the number look normal. The real goal is to safely disarm the emergency and preserve those organs. Thanks so much for diving into this with me, and I'll catch you on the next explainer.